Hi to everyone. As I usually say, my name is Emanuele Neri. I'm the president of the European Society of Medical Imaging Informatics, and I'm very honored to introduce the first webinar of the society. So, good morning, good afternoon, good evening, because our attendees are from all over the world, so time is different. So I thanks all that are attending, and there are still people that are connecting to this webinar. Today's webinar is dedicated to a very hot topic. It's about computer-aided diagnosis with the title From Benchtop to Bedside. And the speaker is Professor Daniel Regge. Professor Regge is a chairman of the radiology department at the Institute for Cancer Research in Piemonte, Candiolo. Is also associate professor of radiology at the University of Turin. Daniel Regge is president of the European Society of Oncologic Imaging, is faculty of the European Society of Gastroenterology, and is the chairman of the Computer Application Committee of the European Congress of Radiology, the incoming Congress in March 2016. So it's my pleasure to leave the presentation to Professor Regge. Professor Regge, please, you are welcome to give your webinar.
Okay, so thank you, Emanuele. Well, there is some good news I see here. We have people from 3 different continents, which is good, and a little bit less good news is that we only have 11 people attending, but I will still do my best to get through to you the message about computer-aided diagnosis. So basically, we are actually, the title of this lecture is From Benchmark to Bedside, but it should be from bedside to benchmark to bedside, because I feel, and I'm a clinician, I feel that we should really start everything with computer informatics applied to medical imaging. We just start with a clinical problem. So we looked a little bit around and to see what good clinical problem would be to start out with. And we looked at cancer. I work in a cancer institution, and we just looked at five most common cancers, the 5 big killers, and we looked through and we thought, well, this should be a nice play, and one of these should be good to start out with to develop a CAD system. And we had experience with colorectal cancer, so we decided to start out from there. But there are other reasons because of this. The first one is that you can perform screening very nicely with this type of cancer. You have as you know, a 5 to 10 year window for the development of cancer through lots of mutations, and if you perform polypectomy on polyps you detect, then you can interrupt this sequence and you can dramatically reduce the percentage of patients that will go on to have cancer. So you can see this very clearly here. This is a very interesting article from JAMA. You can see here that the incidence, because of screening and surveillance, then you can see that the incidence of colorectal cancer has reduced dramatically in 35 years between 1975 and 2010, and the mortality has decreased even more. And this is combined with cervical cancer, the 2 cancers where screening works the best and that have seen the most dramatic reduction in mortality. And you can see here, for example, that this does not hold true for other cancers. We try to screen patients with melanoma, detect melanoma in the skin, but it's not very successful. We have increase in detection, but also increase in mortality. So here, screening is not so effective. The other thing we looked into is we just looked at tests that are used for screening. There are different tests. Some are cheap, but they have a low sensitivity and specificity, and others are more accurate, but they are expensive and poorly tolerated because they are invasive. And also we thought, well, if we look at Italy is a bit of a boot. You can see that there are different there are different. North Italy screening is working very nicely, but the south of Italy is not. There's not very few screening programs going on, and so there's a difficulty in developing screening programs and extending these mask programs, and also to maintain them. So we thought, well, we need a new test, and we thought, well, this test could be new test to examine the colon that could be, accepted, and it could be accurate. And for example, there could be a digital examination, so it could benefit from an infrastructure, IT infrastructure. It could be time efficient and cost effective. And we really started from scratch in the sense that in 2002 we started developing a software, and we thought a nice test could be virtual colonoscopy. We started developing our own software, and we clinically validated this software. This is just one of the articles we published on this, and we developed a method for automatic cementation of colon, basically with automatic positioning of seeds within the colon lumen. These seeds would expand until you could recognize detect the surface, the interface between the mucosa and the air, and then we would remove all unnecessary data. We would interpolate the surface, we would render it with shades and light, and we would get a segmented colon. And we developed a clinical user interface. This is just one. Everybody has its own. You just have to have 2D, both in the prone and supine scan, and the 3D images, and that's fine. You can have multiplanar. And then we validated CT colonography. And what we found out in this study, which was published 6-7 years ago on JAMA, is that we were pretty good at detecting big polyps, but we were very poor in detecting the intermediate sized polyps that are still clinically relevant. So what this is, you can see like a light, and you can see that the green light here means that we get pretty good results. So the red light is poor results. So the low sensitivity for this intermediate sized lesion, and also long reporting times. So we had to enhance our software, and what we did is we developed this CAD system. And we had developed a CAD system also that could detect polyps below the fluid level. So there were different ways of processes. One was that we had to develop a software for digital subtraction, and you can see here how it works. You just simply subtract the tag fluid. And the other point is that we try to identify within the colon lumen those parts of the surface where there was a different curvature, a different shape that could represent a polypoid lesion. So here it is, and all suspicious areas of the surface of the colon were given a different color, or they would put a box around it. Okay, so this is how we developed our CAD system, and we, of course, implemented this CAD system on the pre-existing interface, and here we have it. So what we did next is then we had to measure its performance. So we did this standalone. We just basically tried to have some radiologists just put boxes around the true positives, and then we would, then we would feed the examinations into the CAD system. If the CAD system detected the polyps, then they would be true positives. If they did not detect the polyps, then it would be a false negative. And so we also had false positives. So this way, there are several works. This one in the bottom is ours that show that actually the standalone performance of CAD of the colon is applied to CT colonography. He is pretty good. It's around 90 to 100%. This is what you want to get. above 90% sensitivity, and you also want to not to get too many false positive findings. Okay, you would stay around, let's say, 5 to 10 false positive findings per examination. If you have too many false positives, then it will take you a long time to read the examinations. So what we did then is there are quite a few test examples of how CAD systems have been tested retrospectively, which means in a laboratory, a laboratory milieu. You would put radiologists inside a reading room and they would just report examinations with and without the CAD. But what we did next was to evaluate the CAD prospectively. And this is a study we performed and published in Radiology. There was in 2013. We actually had examined over 600 patients with CAD, using CAD as a double read, in a double reading paradigm. And then we also used CAD as a second reader. We just went through the prompts and we decided which ones were true positives and which ones were false positives, and so on. And what we found out, actually, that CAD was very good in detecting those 6 to 9 millimeter polyps that were missed by the radiologist most of the time. We actually had an increase in sensitivity about 12% on a per patient analysis. No real difference for polyps that were large polyps, those larger than 10 millimeters in diameter. Okay, we actually even saw that this was much better than the previous study, the one published on JAMA, because we would get a higher sensitivity, about 10%, and a reduced drop in reading time. So going back to our lights, we had actually increase in sensitivity for 6 to 9 millimeter polyps, and we had some reduction in reporting time, not satisfactory, just a yellow light. So we decided we would change this and go maybe play with reading algorithms, and we came out with a different reading algorithm, which was computed aided detection was a first reader, but the paradigm was a double reading paradigm. So what we found out here is that so it works this way. It's just the opposite of the previous one. First, we would go through the prompts, and then we would scroll rapidly the 2D images to look for polyps that might have been missed by the CAD system. And what we found out here, that we had pretty much the same specificity and sensitivity as unassisted read, 74% here versus 77% of first read CAD and 77% of double read first read CAD, no drop in specificity, and also that reading times were actually much better, because if we had reasonable number of prompts, we would get reading times which are which were lower than unassisted read. Here, this brownish line is double reading with CAD first reader, and this is unassisted read. So unless we had a large amount of prompts, we would have much faster reading. So this was confirmed by another work published in Investigative Radiology, where we compared first reading with second reader paradigm, and we actually also showed that the most effective reading paradigm was a CAD as a first reader. So here are the results of this study, where you can see that reading times were less, and so CAD first reader is more time efficient and had a similar diagnostic performance to CAD second reader, and should be considered, for example, for mass screening programs where the cost effectiveness is a key issue. So what we did is actually did implement this. This is the result. You can see here that the reporting time dropped. So what we decided to do is to perform a pilot screening program, which we did, and we developed in our region a dedicated IT infrastructure tailored for screening. The tests were performed, I'm talking about always were CT colonography. The tests were performed near in the territory, near the participant's house. It was just, people would just go to the closest hospital, and then all exams were sent to a centralized reporting facility where they were reported by certified radiologists. Okay, so we got all that, and we were able to collect data and so on. And this is the infrastructure. You can see here, examinations actually coming from different hospitals in the region and outside the region. And these are pretty much the results. We just imagine this is a big effort. We invited almost 40,000 people to participate in this trial. And what we found out is that using CAD, we were very fast in reporting, and the CAD alone missed only about 3% of polyps. So this is good news, and we think that we can use CAD routinely in screening programs that will be ongoing in our region with CT colonography. Of course, the last thing we need to know to evaluate cost effectiveness, and this has to, we just have some rough theoretical data. What we are going to do next is to assess cost effectiveness of CTC with CAD based on the real data we get from the screening program. Okay, so this is part one, and it took us about 12 years to develop this whole process from bench to bedside. And while we were working on this and we were almost over, we thought, well, now we have to go on to something else. And we thought about another model. The model was prostate cancer, and of course not CT, but MRI. And why did we select prostate cancer? Because again, the incidence of prostate cancer is very high, the mortality is low. And in this case, it's important to select those patients that would benefit from treatment from those that do not benefit from treatment. So we know now that not all prostate cancers are the same. Some are very aggressive and some are very, very slow growing and don't affect lifespan. So the problem is also that we have some tests here for prostate cancer that are pretty poor test. PSA, it's a blood test, detects protein in the blood, and it has really a very poor performance because it has a low sensitivity and low specificity. When we have high PSA levels, we have to perform biopsy. Normally, this is performed randomly, and we have a risk of missing up to 30% of cancers. And we know now, since a few years, that MRI could be a good exam to select patients that would require further imaging rather than not requiring any imaging at all. And so we started again. We said, well, what's the idea behind developing a CAD system for prostate cancer based on MRI? Well, probably we could put some MRI sequences together, T2 weight, diffusion weight, and dynamic contrast MRI, put them together and develop a probability map of the distribution of tumor within the gland, and probably also measure tumor aggressiveness, which is a very important parameter to know whether a patient should undergo treatment or not. So we thought this was realistic, that it would be also applicable to clinical practice, original. We also thought we could use this system to, for example, guide prostate biopsy, whether either fusion biopsy or also direct biopsy under MR guidance. So for example, we have probability map like this, and we have the needle go to this lesion with very high accuracy and perform a good biopsy. Of course, the first step here is a bit more complicated than CT colonography, which is just, very simple protocol. Here we have to really be able to define a protocol that is optimized, standardizable, reproducible, that it's adequate to extract biomarker. And so we really, what we have to, for example, just giving you some examples, the T2 weight image and the diffusion weight image and the dynamic contrast, they have to have the same slice thickness. And for example, the dynamic study has to have a sufficiently high spatial resolution so that you can get accurate time intensity curves. Then we have to develop a gold standard. Again, how do we go through this? We had to perform MRI on lots of patients. Patients with cancer underwent prostatectomy, and so what we did is correlate the MRI images with the prostatectomy findings, and you can just simply contour the lesion, like in this case you can see here. And this was our gold standard. And then we went through the image processing, and you can see there are different things we have to do. I won't go through the whole thing, but what I give you some examples. For example, we had to develop a fully automatic method to register prostate glands on T2 weight images, dynamic weight imaging, and diffusion weight images. And we had this is some example of this work, and it's fully automatic. It's better, so this way it's reliable and not time consuming. And then we have to extract information. There are different types of information we need to extract, and we can extract information from the dynamic contrast, the wash in, wash out, whatever, maximum uptake, area under curve, time to peak. We have also above, you can see quantitative parameters. And then we have parameters derived from diffusion weight imaging, and specifically ADC or signal intensity on T2 weight images. And then we have to apply this, we have to select the most, we're not going to use all 16. In this case, we found 16, but we are going to have to use a classifier and select the ones that are most probable to detect cancer with respect to benign tissue. And we actually, in our CAD system, we identified these 6, and then we use a classifier to develop a probability map of where the cancer was and where it was not. You can see that here, different color respond to different probabilities. And then, of course, we had to assess what the standalone diagnostic accuracy was, and so we took another testing set, and which was different from the training set, and we actually measured the accuracy of this our PACS, our CAD, sorry, and here you can see on 56 patients we had actually a sensitivity, a per patient sensitivity of 97% with a median false number of false positives equal to 3 on the whole prostate, which is very good work. There's still one step further. Okay, this is just an example of the interface, user interface that we developed. In this case, it's not, it's an academic project. It's not an industrial project like the colon. And in this case, this is a more rough example of an interface, but you can clearly see this is the probability map. Here you have the ADC, and here you have the dynamic, and here you have T2. We went on in this study to also measure aggressiveness, in our case, based on T2 weight magnetic resonance imaging. We wanted to understand if there was a correlation between texture features on T2 weight images and Gleason score, which is the pathological indicator of aggressiveness, tumor aggressiveness. And we found some correlation. So finally, what we did was we still have to complete this. We have to perform validation, and we have to assess efficacy. This is ongoing. We have a large prospective study where we're performing MR under different conditions, and we are also testing our CAD system. Now, just a few slides just to point out to what the problems are about using CAD. First thing, the problem is we're talking about CAD, but in some ways we're also talking, when you can see it's clear, about imaging biomarkers. So the question is here, how reliable are these measurements? And this is a big problem because what do we mean by reliability? We mean that the measurements have to be reproducible, they have to be repeatable, they have to be standardizable. And when I talk about reproducibility, I mean then that the measurement has to be to give the same results at different time points. For example, in using different equipment, or the exam has to, if the exam is performed by different to give the same results if they are repeated a short time after on the same equipment by the same operator. These are the things. But the problem is the problem is that both for reproducibility, especially for reproducibilities, there are many sources of error that can be due to the equipment and the imaging protocol and so on. Also, patient factors can affect the results. And so this is an example of how variations that have been shown for features like K-trans, you can see that reproducibility is very low, as there are extreme variations between 30 and 50%, and things are going a little better with apparent diffusion coefficient, where variations are about between 10 and 20%. This is an example. You can see here, this is a B-value, and ADC for this is for 1,000 B-value, and this is the same patient undergoing diffusion weight imaging with a B-value of 2,000. They look pretty much the same, 1,000, 2,000. But when you look at the ADC values, you see they are different. They have different rock curves. So we don't get the same results. And this is one big problem. It's not reproducible. So, of course, we have to perform the exam also always with the same diffusion weight sequences with the same B-values. So image acquisition, we should try to use, if possible, ideal techniques, okay? But this is not always so easy. So standard methods of diffusion assessment should be established, for example, validated against phantoms, appropriate to specific body locations, with the measurement reproducibility being established. So the quality control is important. Of course, quality controls means lots of things. Phantoms, applications of procedures, and the parameters that are chosen to analyze the results of quality control must be adequate for the identification of errors. So this is a big problem. On the other hand, we have image analysis. So image processing technique must also be standardized so that the results may be compared across centers. This is an example. Here we're using two models to assess ADC. One is a monoexponential model, and one is a bicompartmental model using diffusion plus perfusion. And you can see here that actually what we get different results in terms of values. So this is another big problem. And here again, we can use different metrics, and we have different results. For example, here you can see if we use mean or median or other parameters, then we get different rock curves. So we should standardize also the way we measure ADC. So all of this is, you know, a big problem, and scientific societies like RSNA are approaching this problem, and so there are developing associations, agencies that are taking care, that should be taking care about. And first one is as the Quantitative Imaging Biomarker Alliance. It was started in 2007, and its mission was to improve value and practicality of quantitative imaging biomarkers by reducing variability across devices, patients, and time. See how important it is. And we have other associations in the USA, and you can see they all are under the umbrella of the RSNA, and also in Europe we had actually subcommittees on imaging biomarkers. Emanuele Neri was part of this, and again with the same aims to define possible imaging biomarkers in different human body regions and to identify variations in quantitative results and so on. And eventually what we got is we had, at least in Europe, all these subcommittees were actually put together in one large alliance, which is called the European Imaging Biomarker Alliance, or IBAL, that has to deal with this. So I think I'm over, and this is my town. If you ever want to come here, and this is the Mole Antonelliana, which is a tower, 181 meter tower, which was built in the 18th century and was one of the largest buildings in the world at that time. This is the palace, the royal palace, and this is the food. Food is very good in Torino. We have truffles and we have good wine. So you're welcome to come. So I think I've finished, and I'm, of course, open to any questions.
Okay. Thank you very much, Professor. If there are any questions, please address them on the chat box. So we look at the chat box and wait for your questions. In the meantime, I would like to address one question to Daniele. It's my question. It's about the efforts that one have to spend to develop a CAD. You show the two examples, one of the CT colonography CAD became an industrial product, and you also show the academic version of the CAD for prostate cancer. So one that want to start such experience, how should manage this, how should organize himself? Search for funding, I think, is the first step.
Well, yeah, just sorry about my voice, but my health, my vocal cords are pretty bad today, and after 35 minutes of talk, they're getting worse. But I will do my best. Anyhow, the problem is, first thing, of course, you need to find funds for this kind of research, and you have to have people, computer scientists, working on the issue. Ideally, you should have people embedded in your clinical in your unit or your department, so that they can work very close to clinicians and you can exchange, information all the time. And it's not a big effort probably you would need to have 3 or 4 people working in the project computer sciences. Most of the time, such a project can go on just on a few people, as long as they are well connected with the clinicians. From a more general point of view, I have the impression that this type of research is not on the edge. At least it's not for a cancer institute like mine, where you have lots of other things going on, and especially what is important now is the issue of personalized medicine and trying to find the right treatment at the right time for the right person. And we're a bit on the edge of this, and we're not really considered what we need. People have to understand that imaging is very important to be able to classify tumors properly and to assess the response to therapy.
Yeah. And Daniele, I think that you're talking about the personalized medicine, which will be one of the topic of the next webinar, the 1st of February. I would like to ask you, what do you think about the model of prostate cancer? Because you talk your academics analyze multiple biomarkers coming from different parameters of the patient. So it seems that we are moving toward a CAD that analyze only one parameter or two to a CAD that analyze multiple parameters, multiple biomarkers that should be standardized. So what is going to change? What will be the next, the CAD of the future? In your opinion?
Well, applied to the prostate model, I think what we have to do is to identify patients that have cancer from patients that don't have cancer. Up to now, this was possible only by biopsy. And so ours can be considered, MR can be considered, and CAD could be considered a virtual biopsy. So let's say, for example, perform, like understand a patient has cancer and does not. And once you know the patient has cancer, then the next step is to understand which one is indolent cancer. So you should anyhow not perform anything but follow up from patient that is aggressive, from cancer that is aggressive. And in that case, you have to kind of give a quantitative measure of how aggressive it is. So it has to be related to like pathology and Gleason score, how aggressive, and possibly, and what we're working now on is to, for example, give him classify it according to PRADS, which is the normal way we classify. So so we will have a fully automatic measure of where the tumor is, how aggressive it is, and it will be much easier to understand which patients we should treat and which we should not treat.
And what about including in the information that CAD elaborate some clinical data like lab values and so on?
Well, eventually, in prostate, you know, the problem with the prostate model is that MR is so much superior to any other laboratory analysis, and this has been showing more and more that it probably won't help in this case. What will probably help somehow is probably will be some, demographic thing. Like, for example, age is very important for prostate cancer because, for example, we know that patient is above 75 or 80 years old, you should not treat it. And so it's important to have an age assessment and probably other, clinical condition of the patient. But in the case of prostate, the laboratory analysis like PSA probably would be only a confusing, have a confusing effect.
Okay. Are there any questions from the attendees? Okay, if there are no questions, I don't see questions in the chat box. Just so I think it's time to close the webinar. I would like to thank Daniele Regge for the time spent in preparing the webinar and the time dedicated to efforts dedicated to the webinar today. Thank you very much, Daniele.
Thank you.
In the meantime, yes, and I would like to remind that the next webinar will be the 1st of February. Will be Professor Charles Kahn from the Penn Medicine in Philadelphia, Department of Radiology. He will be talking about radiology reporting in the age of personalized medicine. So I would like to invite you to register for this webinar. Another request, invitation visit the webinar page of, all these webinars are recorded and will be available and are available on the Usomi channel on YouTube. So go to YouTube, you have a look at the webinar that will be held. The today webinar will be available tomorrow. And do remind to fill in the questionnaires at the end when you close, when you leave this chat room. And also, I would like to invite you to apply for membership to the European Society. Thank you, and have a nice evening.
Okay.
Bye-bye.